Did you hit the view already?
Yes, I did. Yeah, it says speaker. We'll see. Good morning and welcome to Pediatric Grand Rounds. The CME code is in the chat box and we'll keep repeating it every 10 to 15 minutes. It's my great pleasure to introduce this morning's Grand Round speaker, whom I know for many, many years. Dr. Arun Saini is Associate Professor in the Division of Critical Care Medicine in the Department of Pediatrics at Baylor College of Medicine and Texas Children's Hospital in Houston. He's also core faculty in the Center for Translational Research on Inflammatory Diseases at Baylor College of Medicine. He received his MD and then completed his pediatric residency in Delhi, India. And after moving to the US, he completed his residency in pediatrics at Children's Hospital of Michigan. And that's where I worked with him for 3 years during his residency training. Subsequently, he did his fellowship training in pediatric critical care medicine at Washington University in St. Louis. He also received his MS in epidemiology in clinical investigation track at the University of Tennessee Health Science Center in Memphis. His clinical and research efforts focus on improving treatment strategies for coagulopathy in critical illness, particularly sepsis-induced coagulopathy. Dr. Saini, thank you very much for accepting our invitation. We are looking forward to your presentation. The floor is yours. Thank you.
Thank you, Dr. Kamath, for your kind introduction and for the invitation. And good morning, everyone. I hope all of you are staying warm in this Texas winter weather. So as Dr. Kamath mentioned that I'm a pediatric intensivist, some of you must be thinking like, why a pediatric intensivist is talking about coagulation? And then the short answer is that as a pediatric intensivist, we see most patients who develop acquired coagulopathy in the ICU setting, and often we don't have expertise of our hemato-oncology doctor to manage this patient who often require therapies within minutes to hours. And that's how my interest in this area developed during my fellowship year, and then I've been working on it. I know, as Dr. Kamath said, in the audience, there are a lot of general pediatricians. There are people who work only in outpatient setting, and some of you are the resident or working in acute care setting, and a few of you are maybe working ICU. So I'm just wanted to go over this presentation where I'm going to introduce a few new concepts and hope those concepts are helpful for you to use in your clinical practice or just increase your knowledge base for future. So as you can see that the title of my talk is Viscoelastic Assays to Guide Therapy in Children with Acquired Coagulopathy. So it's a kind of mouthful. So I kind of break it down in a subsequent slide, what I mean by that. Just before I start my presentation, I have no relevant financial and non-financial disclosure for this presentation. And during this entire presentation, my focus is threefold. First, just to give you guys a clinical context of why understanding of acquired coagulation disorder is important for us as a physician, especially those who work in acute care settings, and what has changed in our understanding of coagulation in past couple of decades, and how a newer coagulation assay assessment, especially looking at qualitative function of the coagulation, can improve how we can assess patients with acquired coagulation disorders and provide therapies. And then I just want to go certain cases with you guys to kind of give you a practice run how to use this assays if you have access to them in your clinical practice. And then I'll end this presentation with some take-home messages. So acquired coagulation disorders is different than congenital coagulation disorder. Congenital coagulation disorder have some specific deficiency of certain factors, and our hematologist colleagues are very well in managing those patients. What acquired coagulation disorders are the disorders which patients develop abnormality in their coagulation in the setting of critical illnesses. Historically, when we used to think of this disorder, we often thought about a bleeding patient who has a decreased ability to make clot or hypocoagulable state. But as our understanding has evolved over the time, we have understood that patient during their critical illness can be in a hypocoagulable state, means like they have an increased tendency of bleeding, or they can go into a hypercoagulable state, which is the tendency to make clots. Especially, we're seeing a lot of our kids are developing deep wave thrombosis or have microthrombosis, small thrombosis in the organs and causing organ failure. But in our day-to-day practice and at bedside practice, we have noticed that these patients often are go into this status can be not static or dynamic. So a patient in their ICU stay can start with hypercoagulable state, may go into hypocoagulable or mixed state. Maybe they are clotting in some area in their body and actually bleeding in some area in their body. And that makes this disorder very complex and often very hard to assess at bedside when we're looking at a patient who's not only bleeding, but also clotting the microvasculature. So that's the first kind of a change in our understanding that acquired coagulation disorder encompasses not just the hypocoagulable state, but they also include hypercoagulable state. And often these states are dynamic and patient may be in mixed state, a combination of both hypo and hypercoagulable. And in the what kind of patient we see acquired coagulopathy. So the percentage is depend on the underlying disorder. This table over here is showing percentage of patient who can develop acquired coagulopathy. So any major trauma like motor vehicle trauma, any severe brain injury, or especially sepsis, major surgeries like surgery for heart, brain tumor, major spinal surgeries. Our oncology patient, a patient with post-oncology microangiopathy or infection, like other microangiopathy, like a hemolytic uremic syndrome, TTP, rheumatological disorder called vasculitis. Many of our patients in ICU now require, we call it extracorporeal support, either heart-lung machine or ECMO. They sometimes require ventricular assist side to support their heart failure, or many of our patients goes in now renal replacement therapy or CRT. And of course, the medication like heparin and warfarin, which are anticoagulant, can all lead to acquired coagulopathy in our patients in ICU setting and in acute care setting. And I'm sure some of our patients now goes outpatient and they're also taking anticoagulation, and those patient population is increasing in past decade or so. So why it's important, why we care about patients who develop acquired coagulopathy is because as we have started to notice that if a patient in acute care setting or ICU setting develop acquired coagulopathy, they have likelihood of more severe disease, and this more severe disease associated with the worse outcomes. So if a patient in the ICU have thrombocytopenia, their likelihood of mortality compared to those who do not develop thrombocytopenia is about 18 times more odds. Similarly, if you have a DIC in the sepsis patient, the inpatient mortality is 3 to 4 times higher than those who do not develop DIC. And a patient with trauma-induced coagulopathy, especially if they develop coagulopathy while they are already in the emergency department, if they present with coagulopathy, their mortality is much higher than those who do not. So in essence, if you have a patient with coagulopathy, they are likely to be more sicker, and more likely they would have increased morbidity and mortality. And then that's where the emphasis is, how can we improve these patient outcome by decreasing morbidity and of course decreasing mortality. And then kind of to do that, we have to mitigate acquired coagulopathy, and how we can do it. How I think we can do it is, to order to understand acquired coagulopathy, we need to actually have a slightly better understanding of underlying coagulation system, what actually our understanding of coagulation system, and how we can use those basic concepts in our understanding of acquired coagulopathy. Secondly, over the past decade or so, we as a bedside clinician started to realize the limitation of plasma-based coagulation assays and the coagulation assay, which just provide you specific numbers, to a more functional evaluation of clotting system where we understand the overall clot formation dynamics and how these clots function in terms of strength and stability. And that actually has started to provide us much better information. And of course, using those tools and information, knowledge base of coagulation system, we can actually apply more targeted intervention, whether it can be blood transfusion practice, or it can be certain medications like antifibrinolytic agent or anticoagulant, and eventually that would all lead to improved clinical outcomes. So this brings to my first part, like what is new in our understanding of coagulation of fibrinolytic process. And I'll start with that. As we all remember medical school trying to learn coagulation cascade, and I never able to learn all the stuff. I memorized multiple times and I always fail to always completely remember the exact steps goes in extrinsic system or intrinsic system. But what it was that in 1940, 1960, a very elegant model of coagulation was proposed by Dr. McFarlane and Dr. Retnoff, and they said it's a biochemical process where activation of either intrinsic pathway or extrinsic pathway leads to a cascade of biochemical reactions which are amplified at each steps, and eventually activated factor 10A, factor 5 calcium phosphorylated, which is sort of a common pathway, increase breakdown of prothrombin to thrombin, and thrombin is what basically break down fibrogen to fibrin. Fibrin is the protein which makes the jello or frame meshwork for the clot, and then factor 12 sort of stabilize this by cross-linking. And that was the understanding of our model, that there is some coagulation proteins. They're kind of activated by certain insert, like either with the extrinsic system, which is tissue factor mediated, or intrinsic system, and that cascade leads to this clot formation. And what we have is we measure this adequacy of this system by either PT-INR, which we often associate with extrinsic system assessment, or we use partial thrombin time to look at intrinsic system. We can measure the fibrogen level to kind of make sure that there's an adequate fibrin level. And of course, we can measure individual proteins in certain settings, but this is what we used to do to assess the system. What is interesting is that in this system, Dr. McFarlane and Dr. Retnoff did not consider cell as a bigger component. They assumed that the cellular component is just providing a phospholipid surface to these reactions to occur. And that's kind of with our understanding of coagulation, kind of in a bigger picture in early 1960s to 70s. But what changed in last 3 decades, or more so in early 2000, is that we understood that this process is not as separated in our blood as we learned in our medical school. So we don't have intrinsic extrinsic system kind of as separated as in our blood as we thought of. And actually, it's a very system where the cells play an important role. Those cells are tissue factor bearing cells, and the platelet. They actually are very integral to a current more accepted model, which we call a cell-based or physiological model of coagulation. And what happened in this system is that whenever there's an injury to vascular endothelium, the tissue factor bearing cell, like such as fibroblasts, get exposed. These cells generate small amount of thrombin, which by activation of factor 10, and this small amount of thrombin activate the platelet in the vicinity. And this activated platelet further generate more thrombin and more activated factor 10, and basically start recruiting more platelets. And as the amount of thrombin generation increased to thrombin burst, that thrombin burst leads to the clot formation. So the process where we learn is intrinsic pathway, extrinsic pathway to change to initiation, propagation, and amplification, and a process where only biochemical reaction was more important to the process. Now we understand the cells are very integral in regulation of amount of clotting and the site of clotting. So that's kind of the change in our understanding of how the coagulation is different, how the coagulation process occur in our body. But in reality, actually, it's way more complex, and I can spend days just talking about the complexity of coagulation system. But what I want you to take from this particular slide is that in order to make the clot in our body, we need plasma factors, we need cells, and the flow within the blood vessels determine the quality of the clot. And these clot actually are distinct based on what factors are driving it, and their properties can be how they form, means the formation and breakdown kinetics, what with the composition of these clots, which can be different diseases, and that changes their structure, and that structure determine the functionality of this clot and how permeable this clot is going to be, how stable this clot is, and then that's kind of a very new understanding. And the more recent literature suggests the clot composition, clot structure, and clot function can have implication not in just acute care setting, but actually in chronic illnesses like a risk of myocardial infection, risk of stroke, risk of peripheral vascular disease in patient with diabetes, and all those factors. So adults actually started to understand that clot characteristics of a patient may have implication not only the acute illnesses, but also in chronic illnesses. But that topic is out of scope for this presentation. But if I can give you one message from this slide, is that we now know that all clots are not the same. And the clot itself has inherent properties, which is determined by the plasma factor, the cells which get incorporated, and then the most important factor is the clot structure. And these structures can determine the functionality of the clot, which has implication on the organ function in our critical care setting. And I'll show you some example what I'm talking about, the clot structure. So this is just to guys to give you an example of what we see. So this is in our labs, we have the swine model of sepsis, coagulopathy. And what we do, we have this piglets, we inoculate this piglet with either E. coli or MRSA, which we collected from our patient in ICU. And then we observe this piglet for up to 72 hours and take serial blood samples. And as we collect this blood, we study these clots made of the plasma through electron microscopy. So I show this picture. So as you can see in a piglet before any sepsis, this is how the clot looks like under the electron microscopy. You can see the fibrin fibers are very smooth. They are like noodles-like, and that looks very uniform, the thickness. And if you just look at it, you see like, okay, this looks like a mesh of a fibrin network, but there is a very smooth pattern to it. But you can see the dramatic change happens when they has developed, the piglet was inoculated with MRSA sepsis. So you can see within 72 hours, the same piglet actually clots change dramatically in structure, and you can see these fibers are now irregular on surface, and we think this irregularity comes because deposition of various inflammatory and other coagulation proteins bind to this clots, which change the property of this clot. And this mesh becomes very dense and abnormal, and the same pattern we saw actually the piglet who was inoculated with E. coli. So that's saying that if you make a clot for a patient who's not infected versus infected, there is a distinct change in the structure and the function of this clot. And when we study this function, clot function like permeability and the strength, we found these clots are less permeable when the piglets are of sepsis, and they also are harder to break down. But does it occur in the patients? So this is reminds the study we did during the COVID pandemic. So I know we all went through it early 2020 and 2021. And if you can all recall that most of our COVID patient has extensive thromboembolic complications, more so in adult than pediatric, but all this patient had in their autopsy finding a microvascular thrombosis in their lung vasculature. They had higher incidence of deep vein thrombosis, a lot of silent MI and stroke in adult population. And so this study, which we did it in our adult ICU in the Veteran Affair ICU at in Houston VA hospital, what we found is uh, the abnormality in clot structure. So I just walk you through this slide just to kind of orient you. So what we did is this is the plasma of a patient we collected, either those who are healthy or those who are admitted in ICU with sepsis associated with non-COVID etiology, and then sepsis because of COVID. And in order to see the fibrin structure, we added fluorescent fibrin in their plasma and used confocal microscopy to look at this clot under the very specialized confocal microscope. And you can just see, looking at the clot structure in a healthy patient, we have a very well-defined kind of a clot structure. There's a lot of black area, means these clots are forming, but they're not very dense. But when you're sick, this clot structure becomes denser, and there's the fiber become less thicker, and there's less room. But as you can see, that COVID patient has a dramatically increased density of clot compared to non-COVID sepsis. And these patients, when we compared for sepsis with non-COVID with COVID, they actually had similar severity of illness. So it's not that severity of illness was driving their clot structure. And so that's where it is like, so though patient has a COVID infection, we realized that this patient has abnormal clots, and that was the reason why this patient actually having more severe organ dysfunction and more thromboembolic complication. And I don't know if you guys can all recall that very early in the course of COVID patient, we started using anticoagulation of any patient who was admitted in an ICU setting, both in adults and in a pediatric setting, which is very unusual for us to use anticoagulation in a patient with viral infection. But that was how we understood and how this knowledge. I would not go into details, but now actually we understand why these clots were denser, and what's driving it is it's because the COVID patient have this viral spike protein which get shed during the viremia, and this spike protein can directly bind to the protein called the fibrogen as the protein. And when it's bind to this fibrogen protein, it changes the clot architecture, and actually been discovered and published in a very elegant work in Nature last year. So that's where we kind of understand what mechanism is actually driving it. So this is the context of how our understanding of coagulation system is evolving from a very simple biochemical model to a very elegant model to a cell-based model where the process is different to now even that clot structure and function is maybe the new way to assess the acquired coagulopathy. So this brings to my second component of my talk is how what can we do to better assess our patient with acquired coagulopathy. And we start to realize that just mere measuring the number or quantity of coagulation factor or quantity of platelets or quantity of fibrogen may not be sufficient for us to understand the underlying abnormality in clot function and then in order to understand that better, we need to have certain qualitative assays which can improve our assessment of how these clots are forming and what kind of a function or strength they have, so that we can kind of translate that into a therapy. So that's kind of where the viscoelastic assays come into the play, and I'll tell you why I think, and that new and upcoming literature suggests that yes, viscoelastic assays can help us better assess patient with acquired coagulopathy. So going back to comparing plasma-based coagulation assay and viscoelastic assay. So as we all know that we very well versed in interpreting our plasma-based coagulation assay, but we are doing it for many years, and they're very useful. I'm not saying that we don't have to use them. I said they are actually very useful, like prothrombin time or INR, partial thrombin time, fibrogen, platelet count, or D-dimer. So extrinsic pathway, partial thrombin intrinsic pathway, fibrogen, just the protein, if it is low, can have abnormal PT and PTT. Platelet counts is very obvious, and D-dimer is kind of marker of how much clot is lysing. But what all of this plasma-based assay has the limitations. First, they don't tell us the quality of the clot forming. They don't tell us what is the strength of those clots are, and also they don't tell us if the patient has a hypercoagulable state. Means like are the patient at high risk of thrombosis and clotting in microvasculature, something which we really need to know in our ICU patient. In comparison to that, viscoelastic assays are where we measure the clot formation in whole blood sample. And what it does, it actually provides a more global understanding of and dynamics of clot formation over time, and actually provide us some assessment of clot strength. And the beauty of these assays are that not only give us if the patient is at risk of bleeding, but it also give us some indication if the patient is at risk of clotting, and that's actually very helpful for us to kind of guide therapies or minimize excessive transfusion or initiate anticoagulation in the patient who are in the ICU or acute care setting. And so that's kind of why I feel viscoelastic assays have use and importance. And then I kind of those who have not used this viscoelastic, have not heard of this viscoelastic, I'll kind of walk you through what they are and how they work. So they're not new, actually. The first and early invention of viscoelastic acid happened in 1940s. And then over time, the technique has more refined and become available to bedside physician. Now we can do viscoelastic assays within in the emergency department. We can do in the ICU, or we can do the OR. We can actually have platform where we can have this viscoelastic assays read live when the clot when the machine is reading. We can actually see the live generation of certain assays numbers, and we can actually we don't have to wait for hours for lab to do PTT and other factors to measure it and get back to us. So we actually can see in real time within 10 minutes to 20 minutes and can do interventions. So it really can save a lot of time and can have a faster, we can have a faster response to our patient needs. So I kind of talk about that we can actually do viscoelastic assay and initiate clot formation in whole blood, either by kaolin, which mimic the intrinsic pathway activation, or we can use tissue factor, which mimics the extrinsic pathway activation. And because this is whole blood and accounting for both the platelets, the white blood cells, so it basically provides more, it's more closer of a mimic or in vivo condition in the patient and more physiological. And it, as I mentioned in previous slide, it provides us the dynamics of clot formation and overall clot strength, but gives some information about the adequacy of platelet function and how these clots are lysing or fibrolytic pathway, and that information is unique to this assay, which has not been provided by our plasma-based assays. So this brings us to what are they? How really we do? What is the technology behind it? So this is a complex figure, but I kind of walk you through and actually give you a very easy example to understand what's happening. So if you can consider a clot as a jello, and many of us have made jello at home. So when we make jello, we boil water, we put the jello powder and let it cool down. As it cool down, the water, which is liquid, turn into gel-like consistency. And the longer we let it settle and put the colder water, the thicker it become. And then if we put a stick in it, in the first you put a stick, you can take it out, but when the stick stays in and then the jello kind of form completely, you cannot take the stick out, it gets stuck in it. So that's essentially is the basis of viscoelastic assay. If you get anything out of my presentation, this is it. We make a jello of the whole blood in a cuvette, and we suspend a stick, which is, we call it a fixed pin. In thromboelastography, we move the cuvette, we move the cup, oscillate 180-degree both sides, and we see if the pin which is suspended it start to move. And once the jellos get thick enough of the whole blood, the pin will start to move, and as it starts to move, it creates the torsion tension in the wire, and that wire has been censored and basically relayed into a graphic presentation. A different form of a different platform of viscoelastic is called a thromboelastometry, or rotational thromboelastometry. In this, actually, the only difference, if looking at, is that instead of moving the cup, we move the suspended pin, and the pin actually moves a lot early on. But as the jello gets thicker, the spin started to move less and less, and that change in the movement of the pin is sensed by optical sensor, and that again give us the tracing of thromboelastography tracing or ROTEM tracing. And there's a new evolving technique, which many of you, I don't know if have your system, is called thromboelastography 6S platform, which consider a more cassette-based setup. The reason using this technology is that many of these assays require larger amount of blood. So to minimize the amount of blood we use, especially in our neonatal population, the company came up with this new technique called thromboelastography. What happened in this technique is that instead of having the cup, we have these channels, and we basically put the blood goes through and get in those small cup-like channels. And then there is the bottom of these channels are open, and then the clots start to form, and then it basically make a gel-like consistency, and then you wiggle this gel and see how much wiggle is there, and those wiggle in the clot or jello. The wiggle in the clot kind of measured by this optical sensor and actually gives into the number. So that's kind of a different technique. But I hope this kind of give you a context. So we basically make a jello of the blood. We suspend the stick and see if the stick is moving. The movement of stick is either sensed by the torsion wire or by the optical sensor, and give us a number and the tracing. So that brings us to what tracing we get. So this is the tracing we get, which is a very classic tracing of thromboelastography. So the x-axis is time in minutes. So often the thromboelastography can be read from 0 to 60 minutes, and in some situations you can go up to 90 minutes. So time is usually in minutes, and can run, the one test can run up to an hour, sometimes 1.5 hours. And then the y-axis is the thickness, or a millimeter, which is basically how far the graph is separated out, and then it comes in. So, and then there are certain parameters we have for this that parameter. We call it the R time, or reaction time. We call it K time, or K kinetics. We call alpha angles. Maximum amplitude lies is at 30 minutes. So those are the 5 parameters we can read out. There are more parameters, but for sake of this presentation, I will stay on these 5 parameters. And then the R time is the surrogate of prothrombin time, or partial thrombin plus time, based on what kind of activator you use to generate the clot. So remember, when we do plasma-based assays, the only information we get is the R time. We don't get any information beyond that. We don't know the dynamics of fibrin polymerization, which is K time. We don't know the strength of the clot, and we don't know how this clot is lysing. So these 4 parameters are actually additional information we get from viscoelastic assay, which we do not have from our plasma-based coagulation assay. The ROTEM, some centers may have ROTEM, and ROTEM is basically very similar in terms of tracing. It's basically, again, axis is time in minutes up to 60 minutes, and then amplitude in millimeter. And then R time is basically labeled as clotting time in the ROTEM reading. K time is been labeled as clot formation time. Alpha angle remains alpha angle. And then maximum amplitude is kind of been label as maximum clot firmness. And of course, lysis index at 30 minutes, and then you can have maximum lysis at like end of the tracing at 60 minutes. One distinction between tag and ROTAM is that in tag, we is one tracing either can be reflective of extrinsic or intrinsic, but in ROTAM we actually get 4 different tracing in through one sample. So it can have XTAM where we activate the clot from tissue factor. It also gives the tracing of intrinsic pathway, and then one tracing called FIPTAM where basically we the clot is only accounting for the effect of fibrogen in the clot. It basically indicate the effect of platelet by putting platelet inhibitor. And then we also have, we call APTAM or aproctentin time, which basically blocks any kind of fibrinolysis. So tell us if the fibrinolysis is hyperactive in these patients. So within a single tracing ROTAM, we can know the tissue factor mediated clotting, we know intrinsic pathway mediated clotting, we can know what's the contribution of the fibrogen, and we can also know if the fibrinolysis is playing a role in our clot breakdown, and all this information can be used in intervention. So understanding what's the technique, understanding the different parameters we get from like a standard tracing from ROTAM and thromboelastography. How can we use them clinically? That's the question often my colleagues ask me, Arun, what can we do to use that? So there is some guidance, and I'll walk this through because that's something we use clinically. So there are 5 parameters which we can often pay attention to, as I alluded in previous slides. The reaction time, R, or clotting time. Basically, it reflects the early clot formation. We have defined normal range. This is more well defined in adult population than pediatric, but we have now normal ground for pediatric population. And if it is prolonged, it suggests there is a deficiency of a component in the plasma, which is usually the clotting factors. In order to fix that, we often transfuse plasma, which is contain various clotting factors. If we see changes of clotting, K-kinetic or clot formation time, and it is prolonged, it suggests that fibrin polymerization is limited or lacking, either because there's a dysfibrogenemia, means the fibrogen you have in blood is not working well, or there's a lack of fibrogen. And to order to correct hypofibrogenemia or dysfibrogenemia, we use cryoprecipitate, which has higher concentration of fibrogen and few additional clotting factor. And K alpha angle is similar, reflecting the same thing, but a different parameter. Once we go in from there to the maximum amplitude, we look into whether the maximum amplitude is less or more. If it is less, it is fine. Either the platelets are lacking or the fibrogen is lacking, and we can transfuse platelet. And if there is excessive lysis, we can actually correct it by using antifibrillary agent or TXA. So these are the numbers we can use. Some people actually believe in just looking at the tracing globally and kind of compare with the normal tracing. So that's another way to kind of look at just looking at the tracing over time. You can use to it. So this is a normal looking tracing. If the R time is prolonged, it looks like this. If the platelets are low, you say the low MA. If low fibrogen, you can have a very kind of pointed long tracing like. And if both platelets and clotting factors are low, you can have a low MA and prolonged R time. If you're prothrombotic, which is extra, you can see increase in the MA only because because of platelet hyperreactivity. If it is a short R time, it is because of the excessive clotting factor activation, and a combination of both. And then if you have a clot lysis, you can have a significant primary fibrinolysis, as you can see in this tapering out of very significant lysis, versus you can have rapid clot formation and then secondary lysis, often seen in DIC. So there's a various way to interpret this tracing, either go by numbers or go by the tracing itself, but definitely it helps us distinguish bleeding tendencies versus thrombotic tendency versus hyperfibrinotic states. And those are extremely helpful for us as a bedside physician to use and apply. So that's covering those 2 aspects. I just often feel people still struggle to use this at bedside. So I thought, how can I explain them better? So the only way can I explain them better to you guys is using some clinical scenarios. So these are truly a real patients we manage in the ICU. I kind of change some numbers to just make it a little bit easier. But these are the true clinical scenarios we often face in our ICU. So the first example is a patient who's usually 10-year-old who has a leukemia, has underwent transplant, and now presented from EC in sepsis. He's in shock, come to our ICU. We draw some labs. We found the patient is thrombocytopenic with platelet count of 25,000, has slightly prolonged INR with 2 and slightly prolonged prothrombin, thromboplastin time 40 seconds. Patient not actively bleeding, but because patient has been sick and required high dose vasopressor, we as a bedside physician has to put a central line. Then the question is, should we transfuse this patient or should we just go ahead and put a central line? And that's where the beauty of our viscoelastic assay comes in, because what happens if I have to transfuse this patient, that I need to order the blood, I have to wait for a few more hours for blood to come before I transfuse. Patient may not develop, get adequate dose of vasopressor, which will prolong his shock stage, may worsen his clinical state, and may cause organ injury. To expedite that process, I did thermoelastography, I got this tracing, and I look at this number. As you see, the R time falls within the normal range, so is the K, so is alpha, and the maximum amplitude analysis. Just looking at this tracing, even if you go back the previous slide, that the tracing looks pretty normal. So just looking at this, I can say that patient actually has a very, though despite of thrombocytopenia and some lack of coagulation factor, overall clot formation potential and clot stability is preserved. So and patient is not actively bleeding, and I'm doing a low risk procedure, so I don't have to wait for anything. I just can go ahead and put a central line. So not only I'm saving 2 transfusion, but also saving time and maybe faster recovery of this patient from septic shock, because adequate vasopressor early on, correcting shock state may improve my patient outcome. So another example of using tech is a patient who often present in us is with a motor vehicle accident and has a moderate trauma. He has a traumatic brain injury based on injury severity score, and patient is still having mild ongoing wound site bleeding. We did the labs, and we say INR is about 2, platelet count is the partial thrombin time is 38 seconds, and platelet 120. So sort of some coagulopathy, but not severe. But patient is bleeding. So and you want to know, do I need to transfuse this patient something more or anything else I can do? And we call it this rapid tag, which gives result within 30 minutes, where basically you're only getting the information of fibril polymerizational analysis. But this rapid tag numbers are here. What you see in this table is that patient has normal R value, because normal K value, normal alpha, and actually slightly decreased MA, means like patient is making clot but not very strong, which makes sense that patient has some degree of thrombocytopenia, which might be playing a role. But what is most profound is this tracing is the severity of clot lysis. So patient is lysing this clot very rapidly. So this is a very common state called primary fibrinolytic state in early stage trauma in this patient. So which is it's extremely common, because the treatment of this is actually not giving more transfusion, because that's going to just make this patient hyperfibrillatory state worse. The treatment is antifibrillatory agent or TXA. So giving TXA of this patient within the emergency setting may improve the patient outcome by decreasing the excessive bleeding, which decrease the exposure to the blood transfusion, and may be able to get the patient to OR safer and faster. And that's very well described in the literature. And I'm not just telling that that's this one specific patient. We have determined that early trauma in this coagulopathy actually is hyperfibrinolytic state. And if it is present, increase the mortality by 10 to 15 times. If it is not present, and actually, apart from the surgical bleeding control, TXA within 6 hours of trauma has been used as one of the agents to minimize the bleeding. Of course, we now do what called balanced transfusion practices in our trauma patient MTP with 1:1:1 ratio, and of course limit crystalloid and permissive hypertension. So The role of TXA over here is much clearer because not all patients would benefit from TXA, but by doing the thromboelastography, we can define those patients. Uh, Another example is a very classic patient we see often is the patient who present with acute liver failure in the setting of viral hepatitis. This patient has a INR of 3.5, PDT of 30 seconds, some thrombocytopenia, fibrogen is 2 gram, no active bleeding. And often these patients with INR 3.5, we get worried that patient might have a life-threatening bleed, and should we prophylactically transfer this patient? But that has inherent issues because one of the marker we use to have a patient to list for transplant in our liver failure patient is INR. So if we artificially correct the INR by giving FAAP, we would lose our ability to monitor the severity of liver failure or timing of liver transplant if the patient requires one. So, and this kind of scenario, can we do thromboelastography and kind of better define the underlying clot formation and clot function? So, as you can see, again, just going back the tracing, it looks a very normal looking tracing, just looking at from the gross tracing number. But then you go specific numbers, all the numbers are fall within the normal range. So it reassures me, though, despite the patient has liver failure, patient has elevated INR, but overall clot formation and function is preserved. So I can sit on the patient. I don't need to do any intervention. I just have to monitor the patient, and that preserve my ability to monitor patient severity of illness and have a timely intervention if patient required transplant and listing for that. And this again has been shown in the literature that the coagulopathy liver failure is different, and it is called a rebalanced coagulopathy because the degree of the lack of anti-hemostatic agent versus prothrombotic agent is kind of happen in all different component of coagulation system, whether it's primary hemostasis, coagulation, and fibrolysis. So that creates, though there's a decreased thrombocytopenia, but there's also high von Willebrand factor and low Adam TS13 is kind of balance out that the primary hemostasis. As there's a decrease in the procoagulant factor, there's also a decrease in the anticoagulant factor. There's also a decrease in hemostatic factor like protease C, protein. So all this kind of balance it out, and so is the fibrolysis. So in the end, the liver failure patient do have abnormal coagulation, but everything is in a balance. We don't have to intervene in this patient because this patient is not at risk of bleeding at the case example. So another example is a 90-year-old patient with appendicitis who has severe sepsis and now coming from the OR has already ongoing bleeding. He has MTP was activated in the OR. Patient received 4 units of RBC, 2 units of plasma, and you have a patient at bedside, open abdomen, and actually bleeding. And the question is, what should we do now? And you got this tracing, which actually is very helpful. It tells you that patient clotting factors are preserved because our time is normal, but patient has very prolonged K value, and also very shallow alpha angle. Means it suggests that patient has either dysfibrogenemia or hypofibrogenemia. The patient also has significantly low MA, which suggests both maybe deficiency of not only just the fibrogen, but maybe a platelet. So in this case scenario, maybe the next step was to not only give, first give cryo, and if the cryo doesn't correct your K and MA, you can go ahead and platelet. But the first component I would give after 4 unit RBC is a cryo. If the cryo doesn't fix the problem, I would go platelet transfusion. You can also do both together, but maybe the cryo may be the first appropriate step to go. Another case example I will show you guys a case of a 14-month-old patient with severe sepsis who's multiple vasoactive infusion. And, it's a classic patient of meningococcemia, and we often see, though it's much rare to see meningococcemia, but we often see 1 or 2 patients with meningococcemia in our ICU. And this patient is here has thrombocytopenia, has prolonged PTA and prothrombin thromboplastin time, has evidence of kidney injury and liver injury. So this is a classic subphenotype of sepsis. We call it thrombocytopenia associated multi-organ failure. And we start to understand this is the phenotype where we have the highest mortality in our patient. And what you're seeing is a tech tracing, and tech tracing or hay is reflective of some degree of consumption of coagulation factors, so the R time is slightly prolonged. The K angle is also slightly prolonged, alpha, and the MA is shallow, but definitely some lysis. So this is sort of a classic intermediate stage of DIC. So in early DIC, we have hypercoagulable state and rapid lysis. Intermediate DIC state is where the consumption started to happen, but not yet widespread, but patients started showing the sign of both the some degree of hypercoagulable state. So this kind of patient, what can we do? Because patient has passed the early hyperfibrinotic state, so TXA may not be the right choice. What we can do is a plasma exchange, where we can taking away, correcting a lot of coagulation factor, and we're taking away a lot of factors which are driving this DIC. And there is some evidence to show that early plasma exchange in a patient with intermediate DIC and TAMO phenotype may have benefit, and now it's one of the recommendation are still weak, but now it's one of the recommendation I a patient to consider plasma exchange in a patient with sepsis subphenotype of thrombocytopenia with multi-organ failure. The last patient I want to kind of talk about, it's very complex, but just some of our ICU colleagues are here who have a patient ECMO. I just want to kind of show that not only in acquired coagulopathy from different condition, even in ECMO, we can use this as a tool to guide therapy. So an example of a 4-year-old patient who's with ARDS, was on VV ECMO for day 2. The patient has mild ongoing cannula site bleeding, and we do a multi-facet coagulation assay. As you can see, we do activated clotting time, we measure INR, platelet, antithrombin level, partial thrombin plasma time, anti-10 level, which reflects heparin effect, and then heparin infusion running at 50. It's kind of a complex patient with so many things. The beauty of thromboelastography is that we can have a standard tech tracing, which may look like this, which is this very prolonged R time, very shallow alpha angle, and very low MA. But we can also negate the effect of heparin by putting something called heparinase, and we can have a tracing which tell us the underlying clotting potential of this patient. And heparinase tag is very different than the kaolin test. So when you look at the heparin tag, you say everything looks pretty normal. So if we negate the effect of heparin in this patient, that the patient ability to make clots is actually pretty normal. So what's going on in this patient? So maybe the problem is too much heparin. So though the anti-10 level is 0.9, but despite of that, patient may have a significant heparin effect shown by the delta R, basic difference between kaolin and heparin R. So tell us that maybe we should lower the heparin, which will decrease the patient bleeding and oozing, and very easy tool to use. And the treatment is decrease heparin infusion. So it guides us how to do the transfusion in this patient. And there's some data to show that thromboelastography can help distinguish bleeding and thrombotic complication in ECMO. I won't go into the detail of that, but there are some evolving data out there. So this brings to the end of my presentation. So I hope I was able to put on the message that first, that acquired coagulopathy is common in ICU patients, especially if they're critical ill. It can have both hypocoagulable mixed state. When it's present, it causes more severe disease and lead to increased morbidity and mortality. Over the time, we understand the coagulation process is more complex than just the interesting and extrinsic pathway. And then clot formation and clot function has implication in both an acute and chronic illnesses. And one of the way to evaluate clot function is using viscoelastic assays, which provides qualitative assessment of the whole blood clot, encompassing both the cellular component, plasma component, and provide us not only the clotting process, but fibrinolytic path. And then using those tools in a specific patient, we may be able to reduce the need for blood transfusion, may provide more specific anticoagulation or antifibrinolytic therapy, and hopefully that will improve the outcome of our patient population. Thank you so much for your attention. I hope this talk was useful for some of you and maybe some new information for some of you. Happy for answer any questions.
Thank you, Dr. Saini. That was a wonderful presentation and educating us on viscoelastic assays, how to use them in critically and non-critically ill patient. There's a question by Dr. Asanasan in the chat box. Has there been any effort to develop standard ranges for TEGs in pediatric population?
Yeah, that's a very good question. Yes, we have a few studies which have looked into a standard coagulation, like the nomogram for pediatric population. And actually, there is an effort towards developing nomogram of neonatal population. The challenge of these assays is the amount of the blood we require to do the assay. So for neonatal population, there is a couple of studies are out there now using the thromboelastography 6X platform, which is a microchip platform, which require almost like a 30 to 40 microliter of blood compared to about 500 to 750 microliter to 1 ml blood for the standard of regular thromboelastography.
This question by Dr. Gong, I think you partially answered that question. How about premature babies? Are there any standards developed for premature babies, newborns?
There is not enough data for premature babies just because the limitation amount of blood required to run of these assays. But the new platform of thromboelastography 6S might provide a little bit more information, but I think these studies are still ongoing. But 1 ml of blood from a premature baby is a lot of blood to collect, and it's very hard to do. But I think when we compare to plasma-based assay, maybe doing either one of them may be better than doing both, and that's I think the data is not strong enough yet as to just rely on only on viscoelastic assay, at least in the neonatal population.
Any other questions, comments for Dr. Saini? So is this a routine practice to use viscoelastic assays now in the PICUs all over the country, all over the world?
Yes,
what is the status?
So for many, so there are certain situations, if you have a level 1 trauma center, you require to have a viscoelastic assays in your hospital system. If you have a center where you provide, we call it a ventricular assist device, you're required to have thromboelastography in your system. In the larger centers, it has become a routine practice. Like in a Texas Children's Hospital, all of our patients who are on ECMO have a ROTEM done every day. So we measure them every day. All of our major trauma patients, we do it. All of our liver failure patients, pre-transplant, post-transplant, intra-transplant, we do it. And all the major surgical procedure, we actually can, this assays can be read and run real time. So they are actually meant to be bedside. So many ORs actually have them in the OR, and you run the assay, you get the tracing, you look at the tracing, and you can intervene as early as within 30 minutes.
Thank you. Any other questions, comments for Dr. Saini? I don't see any comments or questions. Dr. Saini, thank you very much for that really wonderful presentation. I learned a lot myself about how to use this viscoelastic assays. Thank you all for attending this morning's grand round. I'm going to conclude, and we'll see you all next Friday at the same time. Thank you, Dr. Saini, again. Appreciate it.
Thank you so much. Thank you, everyone, for your attention. I hope you stay warm in this and another cold wave coming to Texas.
Thank you. Have a good day. Thank you.